Hey, this is Dr. Madhvi again, and today we'll be discussing about our third question. It's divided into three sub questions. The first one is the umbilical coiling index and its significance. Second is the discuss the type of the cord insertion. Third is the discuss the diagnosis and management of the Vasa Previa. So, see, I've written this answer in this one slide, but believe me, it's a 6-page answer, so don't worry. So first one is the umbilical coiling index. What is UCI? It is the number of the complete vascular coils 360 degrees spiral turns per centimeter length of the umbilical cord. So sorry, normal UCI is number of the complete coils upon the cord length in the centimeter. So this is the normocoil cord where UCI is 0.1 to 0.3 coils per centimeter. Mean is 0.17 to plus or minus 0.09 coils per centimeter. So when we call is hypocoiled cord, when its UCI is less than 10th percentile. Okay, and when we call hypercoiled cord, it's when UCI is greater than 19th percentile. So what's its significance? It's assessed antenatally by the USG Doppler. It's a marker of placental insufficiency. Abnormal coiling needs fetal surveillance. So this is the box where we'll write that its significance. We'll compare it also. See, by making a box or making a diagram or highlighting something, like it helps the examiner to know that you know about that. You can when you can compare, it's easy for examiner to read, to understand. So it's not always that number of paper you fill, it's how you write also matters. So what's significant? This is hypocoil cord, low UCI, there's risk of cord compression, fetal distress, meconium strain like low of casco, fetal growth restriction, and increased perinatal mortality. And for the hypercoil cord, how you say there's risk of fetal hypoxia, fetal growth restriction, preterm birth, umbilical vessel thrombosis, and intrauterine fetal demise. So you can add one point here. I forgot to add that hypocoil cord increases chance of the preeclampsia, PIH. Okay. So the second one is the types of the cord insertion. The first one is the central insertion. Cord inserted in the center of the placenta. Eccentric insertion, cord inserted away from the center. Third one is the marginal insertion, is also called as battledore placenta, where the placenta is inserted within the 2 cm of the edge of the placenta. Filamentous insertion, when the placenta is attached in the membrane near the internal os. So it's called filamentous. And the vessels are without Wharton's jelly. Okay. In the cord, what is cord? Cord is the umbilical artery, umbilical vein, and the Wharton jelly. Okay. But in this filamentous insertion, the only vessels travels through these membranes. Okay. So its significance, that is not asked, just I wrote it because I can also fill some space with it. It's not necessary that you write it. Okay, you shouldn't ideally though. So what's Vasa Previa? So definition is, first, whenever they ask about the diagnosis and management of some condition, then first you do is the define that condition. At least like in this question, it's the question was to discuss the diagnosis and management of the Vasa Previa. When will you diagnose it? When you know it, what it is. Okay. So what is the definition of the Vasa Previa? If you write the definition, you start with the definition or introduction. That will put a very good image in this eyes of the examiner. So they know that you know what is this. Okay. So definition is, unprotected fetal vessels travels the fetal membranes across or near the internal cervical os beneath the presenting part. As you can see, this is the fetal head, this is the membranes, and this membranes, these vessels comes inside the membrane, and then they traverse through the membranes and then attach to the placenta. There are two types of this filamentous incision, type 1 and type 2. In the type 2, there is a succinturate or bilobe placenta. Okay, so the main thing is diagnosis. So, how we diagnose the Vasa Previa? Antenatally is diagnosed by the TVS USG with the color Doppler, where what we see, where the fetal vessels crossing or running the near the internal os. So, or sometimes if the patient is not coming for the antenatal visits, then or the UC facilities are not available, then during labor how we'll know that during labor there will be painless vaginal bleeding after the rupture of membranes, sudden fetal bradycardia or distress, or APTES. It's rarely used now, but you can write it. Okay. So the management is confirmed by the TVS plus Doppler, avoid PV examination, counsel and plan the delivery. Administer corticosteroid at 28 to 32 weeks. Admit at 30 to 32 weeks in selected cases. And elective LSCS at 34 to 37 weeks before onset of labor or rupture of membranes, or if the labor or rupture membrane ruptures, then emergency LSCS needs to be done. Okay. So complications: fetal hemorrhage, severe anemia, hypoxia, shock, IUFD, and neonatal death. Okay, so this was the question. Like, I'll show you that it's not just a one slide question. You can, like, it fills your 6 pages. Okay. So you can see this is the how I wrote the answer. See, first page, second page, third page, fourth page, fifth page, and the sixth page. See, like, I haven't used any colorful pen or markers here. It's like when you are writing a 10 marks question, like there are 10 questions there. It's not necessarily that every question we can make diagram. Sometimes we have to write the theory also. So we have limited time period. So if you like just color the things, you'll waste your time in coloring the things or using different pencil or pens. So it's not advisable. Like in this answer also, the examiner can know that you know what's its umbilical coiling index. Like you just highlight the important points. Okay, you make a diagram that examiner can just understand. You don't have to color it. So this is my strategy. Is not necessarily if you feel that you can you can like color the diagram and whatever you make a like very sophisticated diagram you can make with time limit. It's all good. Okay, but for me I think it's sufficient, so I'm not going into that precise diagram and color diagram thing. So see, 6-page answer. Okay, so if you think that you can write in an even better way, you can also text me, DM me, or you can just comment below. And if you like the content, please like the video and share with your friends who are doing DNB. And bye bye, see you in the next video.